A good day to everyone. Today we'll be discussing a postgraduate module on autonomic function testing. Now, autonomic function testing, as the name suggests, is basically a series of tests designed to assess the function of the autonomic nervous system. Now, the nervous system and the endocrine system are two regulatory systems of the body which are involved in the control of distinct physiological processes which are distributed at various locations in the body. Now, if we see the endocrine system, for example, the endocrine system achieves control at distant sites through the production of various hormones and circulating chemicals which eventually act at distinct effector organs on distinct receptors producing an effect. And whereas if we see the neural system can be divided into three parts. There is the central nervous system, there is the peripheral nervous system, and then there is the autonomic nervous system. So, if you see the central nervous system, as the name suggests, it contains the central neural tissues. So, the most important neural tissues in our body are the brain and the spinal cord. The peripheral nervous system basically consists of the nerves through which the central nervous system supplies the various tissues of our body. So, there are 12 pairs of cranial nerves which arise from different parts of the brain stem, and then there are 31 pairs of spinal nerves arising from the cervical, thoracic, lumbar and sacral parts of the spinal cord. And then there is the autonomic nervous system. Now, if we see the autonomic nervous system can broadly be divided into three components. There is the sympathetic nervous system, there is the parasympathetic nervous system, and then there is the enteric nervous system. So, we will study the structure of the autonomic nervous system to begin with, so that we can understand what are the disorders that can take place in autonomic function, and then how would we go about testing these disorders, right. So, over the course of today's presentation, we will be going through in a sequence. So, first off we will start with studying the organization of the autonomic nervous system, what is the neural structure of the autonomic nervous system, and then we will see what happens when the autonomic nervous system is deranged, so called autonomic dysfunction or dysautonomia. And then once we understand how autonomic function can be deranged, we will work on how autonomic function testing principles work, how can we devise various tests to assess autonomic nervous system. So, broadly if we see clinically, the tests available today can be broadly classified into three types. The first type is cardio-autonomic function testing, which basically assess various cardiovascular reflexes involved in the regulation of BP. And then there is pseudomotor testing. Pseudomotor is basically the sweating response. And then we can also directly assess the neural activity and neurotransmitter assays related to various autonomic nervous systems, hormones and autonomic nerves. Right, now if we see the autonomic nervous system, so as you can see, the autonomic nervous system is distributed through various levels of the body. Now, broadly speaking, the enteric nervous system is a self-contained nervous system present within the GIT. It is present within the layers of the intestine and also in the stomach, and thereby it serves to serve a regulatory role in the control of secretion and the motor function of the GIT. And if we see the enteric nervous system, it is one of the most primitive nervous systems to develop, and it is also in communication with the other two domains of the autonomic nervous system, that is namely the parasympathetic division and the sympathetic division. Now, coming to the two major domains, the parasympathetic and the sympathetic. So, broadly speaking, the parasympathetic nervous system is called the feeding system, whereas the sympathetic nervous system is called the fight or flight system. So, this refers to some of the various responses, how all of them accumulate together to produce an effective effector response. So, if you see the sympathetic system, all the responses produced by the sympathetic system are geared towards producing what is called the fight, flight and fear response, in which your body's resources are mobilized so that the body can quickly respond to any abrupt changes in the environment which can be of potential survival benefit. Whereas the parasympathetic nervous system can be called as what we call the feeding and growing system, in which the body tends to assimilate and undergo anabolic changes. So, if you see the structure of the autonomic nervous system, so basically autonomic nervous system is under top-down control from the central nervous system. The hypothalamus is the key regulator for both sympathetic and parasympathetic nervous systems. Now, if we see the sympathetic nervous system or parasympathetic nervous system, they are under what is called as top down control from the central nervous system. So they receive controlling influences from the hypothalamus and medullary centers. Now if we see the neural components of the sympathetic and parasympathetic nervous system, they can be classified as preganglionic, autonomic ganglia and postganglionic, right. So if we see the sympathetic nervous system, it is called the thoracolumbar outflow because the preganglionic fibers come from the thoracic and lumbar spine, and then the preganglionic fibers synapse at the autonomic ganglia, which are present in something called the paravertebral sympathetic chain of ganglia, and from there postganglionic neurons go to various effector tissues of the sympathetic nervous system. Now similarly, if we see the parasympathetic nervous system, it is called craniosacral outflow. It is called craniosacral outflow because cranial nerves, which is nerves number 3, the oculomotor nerve, nerve number 7, the facial nerve, nerve number 9, the glossopharyngeal nerve, and nerve number 10, the vagus nerve. These form the preganglionic neurons, and they synapse at parasympathetic ganglia, which are very close to the effector organ. Similarly, the bowel and bladder are innervated by what we call the pelvic splanchnic nerves arising from the S2, S3 and S4 spinal segments, and thereby this architecture, the preganglionic, ganglionic and postganglionic architecture, is conserved across the autonomic nervous system. Now coming down to the effector responses seen by the autonomic nervous system. So that as you can see, most the sympathetic and the parasympathetic ganglia have counter innervation of multiple tissues. That is, they innervate multiple tissues starting from the top of the body to the bottom. We can see them innervating the iridial muscles of the pupil. We can see them innervating the trachea. We can see them innervating the heart. We can see them innervating multiple GI structures, and then we can also see them innervating the bowel. So usually they have a countering effect on each other. So for example, the sympathetic system would dilate the eye, whereas the parasympathetic system would constrict it. Similarly, at the level of the heart, the sympathetic system would lead to an increase in heart rate, whereas parasympathetic stimulation through the vagus would lead to a decrease in heart rate. Similarly, at the level of the lungs and the trachea, sympathetic stimulation would lead to bronchodilation and bronchoconstriction in the case of parasympathetic stimulation, right. So as you can see that the countering effects at each levels, at the level of GI secretion, at the level of cardiovascular, at the level of GI motility, at the level of adrenal medulla, and at the level of urinary bladder and rectal control, the sympathetic system and parasympathetic system have countering influences. Now what would happen if there is a derangement of autonomic dysfunction? So autonomic function is necessary for the day-to-day regulation of BP. It is involved in the beat-to-beat regulation of BP. It is involved in the control of bowel and bladder habits. It is involved in the control of sweating, thereby contributing to thermoregulation. It is involved in maintaining multiple vital reflexes like the light reflex, in which the light reflex allows the eyes to adapt to a wide range of ambient illuminations, thereby when there is dim light there would be dilation, and when there is bright light there would be constriction to control the amount of light entering the retina through the pupil. And then also there can be multiple disorders of GI secretion and GI dysfunction. The autonomic nervous system is responsible for maintaining the various responses elicited during exercise. So if you see autonomic dysfunction can manifest in a very diverse range of symptoms. So the most common manifestation of autonomic dysfunction would be what is called postural hypotension or and an extreme case postural syncope. So hypotension is a fall in BP, and postural hypotension is a fall in BP brought about by a change in posture. So usually if we see there is a small change in BP present during different changes of postures from supine to standing to sitting, and usually BP is found to be slightly lesser in the standing position compared to the supine position, and this is because of a caudal shift, as in blood which is present in the central part of your body is shifted down into the lower limb veins. The lower limb veins are what we call capacitance vessels, and they can expand to fit in the extra amount of blood coming in. Now usually what happens is there are certain reflexes in our body, namely the baroreceptor reflex, which judges a fall in central blood volumes and thereby increases the BP through increased sympathetic stimulation to the heart and also to the venous vessels. So whenever there is venoconstriction, there is constriction of these veins and this blood shifts back to the heart. Now what happens in autonomic dysfunction is whenever you adopt a standing posture, all this blood pools up in your lower limb veins and doesn't reach the central parts of the body. So because of this there can be hypotension, and in extreme cases of postural hypotension, when there is a reduction in the cerebral blood flow, there can be a transient loss of consciousness, and this is called postural syncope. And similarly, if we see the bowel and bladder habits, now the bowel and bladder habits are under voluntary control, whereas the muscular responses, the motor control of this bowel and bladder is through the autonomic nervous system. So the autonomic nervous system innervates both the musculature, in this case the smooth muscles of the bowel and bladder, and also the sphincters. So whenever there is a dysfunction of autonomic nervous system, there is a dysfunction in the regulation of bowel and bladder habits. Similarly, anhidrosis is basically a loss of the sweating response. So sweat glands are of two types, the eccrine glands and the apocrine glands. So eccrine glands have straight tubules and are involved in sweat production for the purpose of thermoregulation. So thermoregulation is under the control of both systems. There are the thermal receptors which send sensory information to be integrated at the level of the medulla and the hypothalamus, and then the downstream effector responses. So sweating is one of the downstream effector responses involved in thermoregulation, and sweating is under the control of cholinergic postganglionic sympathetic fibers. So as you can see, even though it is a sympathetic system, the sweat glands are special in a way that they are innervated by cholinergic sympathetic neurons. So usually acetylcholine is the neurotransmitter seen in the postganglionic parasympathetic system, but in this case it is the sympathetic system of the sweat glands which also shares the acetylcholine receptors and the acetylcholine neurotransmitter. Right. So now what are the different cases in which we see autonomic dysfunction? So most commonly autonomic dysfunction is usually secondary in origin due to another form of systemic disease. So the most common form of autonomic dysfunction is seen in diabetic neuropathy. So in diabetic neuropathy we see people complaining of paresthesias, we see people complaining of altered bowel and bladder habits, we see people complaining of postural hypertension and the classically described symptoms of autonomic dysfunction. Now some of the other rare cases are what we call primary autonomic dysfunction disorders, in which the neural structures of the autonomic nervous system can be affected. So there are some specific neural structures like spinocerebellar ataxia, primary autonomic dysfunction disorders, and all these are slightly rare. So whenever you investigate, whenever you receive a subject for whom you suspect autonomic dysfunction, one of the first things you would want to do is rule out the presence of any secondary disorder which could have led to the autonomic dysfunction. So usually diagnosis of autonomic dysfunction is made on clinical grounds, and then this diagnosis will need to be confirmed objectively through the use of autonomic function testing. So if you see autonomic function testing, there are some basic general principles involved in autonomic function testing. First thing is you want to quantitatively evaluate, as in how is the autonomic function deranged. If it is deranged, what is the extent of the derangement? Like what is the severity, what different domains are obtained, are affected, is it just the sympathetic system, is it just the parasympathetic system, or is it both, does it involve multiple tissues of the body, or is it more or less localized? So all of this must be tested through autonomic function testing. And similarly, once the diagnosis is established, the autonomic function testing protocols can also be used to monitor the course of the disease and also responses to any therapy instituted for the treatment of the disease. And similarly, there are a few research uses in which we study autonomic dysfunction. Right. Now if we see the various tests used in autonomic function testing, so usually an autonomic function testing laboratory needs to have certain equipment. So the most commonly used protocols in autonomic function testing, as I said before, involves testing cardiovascular reflexes through cardio-autonomic testing. So, the requirements for cardio-autonomic testing, the most basic requirements would be an ability to record ECG, an ability to record the respiratory activity. So, ECG is recorded using an electrocardiogram, and a digital ECG has advantages in data analysis. Similarly, respiratory activity can be tested through stenography, and then you will also need an equipment to measure BP. So, BP can be measured clinically through sphygmomanometers, but recording beat to beat BP through the usage of non-invasive BP devices like FenaPress or PortaPress would improve the quality of autonomic testing that can be done. And similarly, pseudomotor testing is assessment of the sweating responses. Right. For this, what we do is we basically create thermoregulatory stresses which would eventually lead to development of a sweating response which can be quantified. And similarly, nerve activity of some local tissues like the skin and the muscle can be directly tested, and neurotransmitter assays can be assessed through urinary testing or blood testing. Right. So, coming down to cardio-autonomic function testing. So, cardio-autonomic function testing is the go-to mainstay for any well established autonomic laboratory. So, within the cardio-autonomic function testing, we have a group of tests called the Ewing battery. So, Ewing battery is a group of 5 tests which involve measurement of BP and ECG parameters, and creation of certain autonomic stresses which would elicit changes in BP and heart rate, and basically quantifying the autonomic dysfunction through specified qualitative and quantitative responses. Then heart rate variability is basically the ongoing fluctuation in the heart rate, which is due to a balance between the sympathetic and parasympathetic descending influences on the heart. Whereas baroreflex sensitivity allows us to test the sensitivity and the function of the baroreflex arc specifically. So, each of these 3 tests are basically based on the cardiovascular reflexes, the dominant reflex being the baroreceptor reflex. So, we will need to understand the baroreceptor reflex a bit before we proceed with the cardio-autonomic function testing. So, if you see the baroreceptor reflex is designed for the maintenance of central blood pressure, systemic blood pressure. So, the baroreceptor reflex has a sensor. The sensor is usually a mechanoreceptor which is present in the aortic arch and the carotid sinus. So, the carotid sinus is present at the internal carotid artery and is sensitive to wall stretches brought about by differential amount of filling. So, anytime there is a reduction in blood pressure, there is a reduced firing of the baroreceptor, and similarly when there is an increase in blood pressure, there is an increased firing of the baroreceptor. So, the efferent pathways for the baroreceptor reflex are the glossopharyngeal nerve and the vagus nerve, and these relate through upwards to the sensory nucleus of the solitary tract, the NTS or the nucleus tractus solitarius, and from there descending influences go to various medullary centers. So, there is a medullary dorsal motor center for the vagus, and then there is a rostroventrolateral medulla which is also called the vasomotor center. So, the vasomotor center sends downstream influences to the intermediate lateral horn of the spinal cord, from which we see the preganglionic neuron arising towards the sympathetic ganglia, and the dorsal motor nucleus sends a preganglionic vagal neuron through which the heart is controlled. So, one of the responses of the baroreceptor reflex is an increase in BP would lead to increased vagal activity, decreased sympathetic activity, leading to a decrease in the heart rate, and also a decrease in the amount of vasoconstriction in the systemic circulation. So, the baroreceptor reflex responds to an increase in BP by instituting certain responses like a decrease in cardiac output and a decrease in the vascular tone, which would basically lead to a decrease in BP to counter the initial change, and the exact opposite changes take place whenever there is a fall in BP. So, the baroreceptor reflex regulates systemic arterial pressure in a range of 60 to 160 millimeters of mercury. So, now if you see the Ewing battery, the Ewing battery consists of 5 clinical tests. Each of these tests can be done in an autonomic function laboratory through a simple clinical maneuvers. So, the 5 tests which compose the Ewing battery are the head up tilt or lying to standing test. Both of them involve a similar protocol. Then there is the deep breathing test, there is the valsalva maneuver, there is the isometric hand grip test, and the cold pressure test. Now we can go into the individual details of each of these tests and the maneuvers involved in performing this test. Right. So the first test in the Ewing battery is the head up tilt or the lying to standing test. So the principle of the head up tilt or the lying to standing test is giving a postural challenge to the body. So what happens in each of these tests is the body is quickly transitioned from a supine posture to a standing posture. Now in the head up tilt, this is done passively. So to accomplish a head up tilt, what we use something called a tilt table. So as you can see in this picture, the tilt table consists of a table on which with a foot support at one end, on which the subject is initially supine, and the table can be passively tilted to to an angle of our choice with either the head end up or the head end low. So during the head up tilt, what is being done is the subject is placed on the table in a rested state, and then the table is passively tilted from an angle of 0 degrees to an angle with the horizontal to an angle of 70 degrees with the horizontal, and this tilt has to be accomplished quickly within a period of 10 to 15 seconds. So basically the purpose of this test is to quickly obtain a transition from the supine state to the standing state. Now whereas in the lying to standing test, that's a more active procedure. So what happens during the lying to standing test is initially the subject is supine, and then the subject has to obtain a standing posture within 3 minutes. So for that, what is done is it's done in 3 stages. In the first second, the subject sits up. In the second second, the subject swings his legs across to the side of the table so that they hang down of the edge of the table, and then in the third second, the subject hops off the table into a standing posture. And both head up tilt and the standing posture accomplished during a lying to standing test will have to be maintained for a period of 5 minutes. So, and while this process is going on, both BP and heart rate are constantly measured. So we can measure heart rate indirectly from the ECG through RR intervals, and BP can be measured either through a sphygmomanometer or through the use of a non-invasive BP measurement device. So BP measurements and RR intervals are measured constantly. BP is, if sphygmomanometers are used, BP has to be measured once every minutes. So there are 5 measurements through the 5 minutes of the standing posture, and after which, at the end of which, the standing posture is reversed back into a supine position, and the recovery BPs are also measured. So at any given point during this standing posture, if there is a fall in either systolic BP or diastolic BP greater than 10 millimeters of mercury, it is considered abnormal. So less than 10 millimeters of mercury is considered to be an acceptable response, a fall in BP that is, and whereas 10 to 20 is considered borderline abnormal, and greater than 20 millimeters of mercury fall in BP in either systolic or diastolic is considered to be outright abnormal. And similarly, as you can see, there is something called a 30-15 ratio, right? So as you can see, this data recorded here represents an ECG record obtained during the first minute after an active change in posture, in this case a lying to standing test. So initially they could see a few motion artifacts in the ECG when there was a change in posture, and whenever there is a change in posture, there is a passive shift of blood volumes to the lower limbs, which would lead to a corrective response in the heart rate to the baroreceptor reflex. So we expect the baroreceptor reflex to be operational and institute corrective responses within 6 to 7 seconds, so that by 15 seconds the BP is back to normal, and at the end of 30 seconds, the heart rate falls again because the BP has already been corrected. So to assess the heart rate response brought about by the baroreceptor reflex in the lying to standing test, there is an index called the 30 to 15 ratio. So what we do is we take the maximum RR interval at a period of corresponding to roughly 30 cycles after the change in posture, and take the ratio of that with the 15th cycle after the change in posture. We take the ratio of the RR intervals of the 30th cycle is to ratio RR interval of the 15th cycle, and we compute this ratio called the 30-15 ratio. and the 1350 ratio should be greater than 1.04. Values less than 1 are considered abnormal, and values from 1 to 1.04 are considered borderline. Right, now if you see the deep breathing test, in the deep breathing test what we do is the subjects are basically asked to exaggerate a normal phenomenon. So the normal phenomenon being something called respiratory sinus arrhythmia. So even during in a normal resting individual, there are small fluctuations in the heart rate brought about by breathing activity. So whenever there is inspiration, there is a small increase in heart rate, and whenever there is expiration, there is a small decrease in heart rate. Now this phenomenon is called respiratory sinus arrhythmia, and this is explained in terms of cardiorespiratory coupling at the level of the medulla in the regulatory centers. Now in deep breathing, what we are trying to do is we are trying to exaggerate this observed normal phenomenon. So the subjects are expected to take deep breaths. So the subjects are given instructions that to take 6 cycles of breathing in 1 minute. Each cycle would last for 10 seconds each. Now within a given cycle, the first 5 seconds would be a deep slow inspiration, right, and the next 5 seconds would be a deep slow expiration. So what you are doing is slow and deep breathing. So as you can see in the data recorded earlier, the topmost channel, the one in red, shows an exaggeration of the normal respiratory pattern, in which upwards represents inspiration and downwards represents expiration. And then heart rate can be measured using ECG and RR intervals. So as said earlier, we expect the heart rate to go up during inspiration, thereby RR intervals are lower in inspiration, and heart rate falls down during expiration and RR intervals are higher. So what we can do is for each cycle of breathing, like one cycle is 10 seconds. So what you can do is measure the RR interval in expiration, maximum RR interval during the expiratory phase, and divide it with the maximum RR interval seen during the inspiratory phase. And for this we will maximum during the expiratory phase divided by minimum in the inspiratory phase. So this gives us a ratio called the EI ratio, expiratory inspiratory ratio. So similarly, the EI ratio is computed for each of the 6 cycles separately and then averaged together to give the EI ratio for the entire maneuver. And the EI ratio is expected to be greater than 1.21. Values lesser than this are considered abnormal. Right. Now coming down to the valsalva ratio. So the valsalva is a very specific maneuver. So the valsalva maneuver is a clinical maneuver done for specific reasons. It's done to equalize the pressure between the middle ear cavity and the nasopharynx. So usually valsalva maneuver is done whenever you are in pressurized aircrafts or whenever you are scuba diving and you wish to equalize pressures between the airways and the pharynx. And so the valsalva maneuver used in cardio-autonomic testing is slightly different. The classical valsalva maneuver is produced against a closed glottis, whereas the valsalva maneuver used in this testing involves producing a forced expiratory effort. So what is done is the sphygmomanometer is taken, the cuff going on the hand is detached from it, and a mouthpiece is attached to the tubing going to the mercury column, and the subjects are instructed to place the mouthpiece in their mouth and gently produce a forced expiratory effort, trying to sustain the mercury column at 40 millimeters of mercury. And this is a small leak in the tubing, thereby preventing the closure of the glottis. So the instruction is, at the start of the maneuver, blow out as hard as you can, trying to maintain a pressure of 40 millimeters of steady pressure of 40 millimeters of mercury in the mercury column. And the valsalva maneuver has classically 4 described phases. So the first phase is the start of the maneuver, then the second phase is during the maneuver, the third phase and fourth phase are at the end of the maneuver. So what happens during the first phase is, they say, because of a sudden constriction developed with a forced expiratory effort, the pulmonary circulation and the pulmonary vessels constrict, leading to a transient increase in venous return. This venous return is associated with a corrective fall in heart rate due to the baroreceptor reflex. And then as the extrathoracic pressures, intrathoracic pressures stay higher, the venous return falls during phase 2, and this is corrected by an increase in heart rate. Now during phase 3, between phase 2 and phase 3 of the valsalva maneuver, the pressure is released. And what happens during phase 3 is now pulmonary vessels which were initially constricted due to the increase in intrathoracic pressure now re-expand again. So while they are re-expanding, there is again a decrease in venous return. So this is corrected by an increase in heart rate. And finally at the end of phase 4, the venous return is restored and the heart rate comes back to normal. So we have a scenario where the heart rate is increasing during the maneuver and RR intervals are decreasing during the maneuver, right? And similarly at the end of the maneuver, RR intervals are increasing and heart rate is decreasing. So the valsalva ratio takes the ratio of the maximum RR interval after the maneuver and divides it with the minimum RR interval during the maneuver. We get something called the valsalva ratio. Post maneuver RR interval divided by pre maneuver RR interval, and the valsalva ratio should be greater than 1.21. So as you can see in each of these tests, we are basically quantifying heart rate responses, and quick changes in heart rate are usually due to a change in parasympathetic reactivity. So tests like the 30-15 ratio, tests like the expiratory-inspiratory ratio, the EA ratio in deep breathing, and the valsalva ratio in valsalva maneuver are serve as a function assessment of the function of parasympathetic nervous system. Right. Now there are some tests in which we measure BP. So we saw a measure of BP in the active lying to standing or head up tilt. Now there's some other autonomic function tests in which we study BP responses. There's the isometric hand grip test and the cold pressure test. So in the isometric hand grip test, what is done is an isometric hand grip exercise is done at 30% of the maximum voluntary contraction. So maximum voluntary contraction is by forcibly contracting it as hard as you can. We can measure that on a hand grip dynamometer, and then subjects can be instructed to maintain a sustained hand grip at a slightly lesser intensity, which is 30% of the maximum. And what we do is we measure the BP in the contralateral hand during this. So if you are doing it with the right hand, we want to measure BP in the contralateral hand, and we measure the BP, and if we expect an increase in diastolic pressure greater than 10 millimeters of mercury when isometric hand grip is being done. And similarly, the cold pressure test involves thermoregulatory increases in BP. So there is a thermoregulatory pathway. For this, the hand is immersed in cold water. So cold water should be around 5 to 10 degrees Celsius, and the hand is immersed for around a minute. And then the diastolic BP is measured during this period. And at diastolic BP, increase of at least greater than 10 mm of Hg is expected. So broadly speaking, the cardio-autonomic tests study both heart rate responses and BP responses. So all the heart rate responses can be attributed to parasympathetic function, and all the BP responses can be attributed to sympathetic function. So if we see the Ewing battery, we accumulate the results of all of these 5 tests together and thereby quantify the output, quantify the test in terms of altered parasympathetic reactivity or altered sympathetic reactivity or both. Right. Heart rate variability is used in more of a research setting. So there are specific parameters taken in ECG analysis. So what is being done is we record ECG. We record ECG for a continuous duration of around 5 to 10 minutes or longer if necessary, and then specific analysis parameters can be computed from them. So there are various parameters like SDNN, SD average, and then root mean square of the standard deviation, then percentage of NN intervals which differ more than 50 milliseconds. So each of these basically involve analysis of the RR intervals and to see how much the heart rate variability is there. So heart rate variability is a normal phenomenon representing the interplay of sympathetic and parasympathetic tones. Similarly, heart rate variability can be studied in the spectral domain, which is a frequency domain also. So a fast Fourier transform is executed on the RR interval and the ECG data, and we can see the spectral power under low frequency, which is 0.02 to 0.15 Hertz, or spectral power under high frequency, which is 0.15 to 0.4 Hertz. So low frequency oscillations are usually brought about due to sympathetic activity, whereas high frequency oscillations are brought about by parasympathetic activity. This is because acetylcholine decays faster, and thereby any changes in parasympathetic system are seen in the form of slightly higher frequency oscillations. And the LF, which is a low frequency by high frequency ratio, will give us the balance of parasympathetic and sympathetic descending influences on the heart. Right, baroreflex sensitivity. So now if you see the baroreflex reflex, but the baroreflex institutes correctional changes in responses to spontaneous fluctuations in the BP or induced fluctuations in the BP. So the correction is in the form of a change in heart rate which can be assessed through RR intervals. So for this, what we need to do is record ECG and non-invasive BPs simultaneously, see the fluctuations in BP which are present spontaneously, and see how RR interval changes. So what you can do is divide the delta RR interval change by the change in mean arterial pressure, and this gives us a reflex of the baroreflex sensitivity. So baroreflex sensitivity and heart rate variability are used in conjunction together to study the baroreflex in specifically and to study the cardio-autonomic function. So cardio-autonomic function is the go-to hallmark for testing of autonomic function in the case of generalized autonomic function disorder. Right, now if we see pseudomotor testing, now pseudomotor testing is done more in the case of a specified group of autonomic disorders. So the purpose of pseudomotor testing is the assessment of the sweating response, and as I said earlier, the sweating response is mediated through postganglionic cholinergic sympathetic neurons. So there are different protocols for doing pseudomotor testing. There is something called the sympathetic skin response, there is something called the thermoregulatory test, and there is something called QSAT, the quantitative pseudomotor axon reflex test. So both in the SSR, sympathetic skin response, and thermoregulatory test, a thermoregulatory challenge is presented to the subject, in which the subject is exposed to warm temperatures and sweating is quantified from different parts of the body. So what is usually done is there are certain indicators which can change color based on exposure to moisture, and then on the topographic distribution of the sweating response to see which areas are responding and which areas are not, and the quantitation of the sweating response can be done. In QSAT we do a slightly modified localized one. We use a technique called iontophoresis, in which acetylcholine is placed over the skin and is taken up transcutaneously, and this acts through a mechanism called the axon reflex. So axon reflex is basically a reflex in which acetylcholine acts on the same axon. This impulse is propagated in a retrograde manner and thereby activating the axon, and then it's again repropagated, thereby leading to a sweating response. Right. Finally, we can also do localized studies of the autonomic nervous activity and neurotransmitter levels. There is the technique called microneurography, in which small electrodes are placed at the various autonomic nerves near the muscle and the skin, and we can quantify their activity in terms of bursts of firing. And similarly, circulating neurotransmitter assays can be done through the assessment of plasma norepinephrines, and similarly the catabolites of catecholamine metabolism like urinary metanephrines and vanillyl manolic acid VMA can be measured. So coming down to this, as you can see, the autonomic nervous system is a very important system in the regulation of multiple body processes, and it can manifest with symptoms like postural hypertension and heat and exercise intolerance. So what you want to do is evaluate and quantify the amount of autonomic dysfunction better. So the Ewing battery, which is the battery of 5 tests which involve BP and heart rate responses to various challenges, is a very quick and robust test. The entire Ewing battery can be performed within around half an hour, and it can be used to differentially evaluate both parasympathetic and sympathetic function. Whereas other tests like heart rate variability, baroreflex sensitivity, pseudomotor testing, microneurography and neurotransmitter assays can produce information, and this information is of both clinical and research relevance, and eventually all information will have to be correlated clinically to aid the diagnosis of autonomic dysfunction disorders. Thank you.